Hello, everyone, and welcome to the HHQI Cardiovascular Learning Action Network, or the CardioLAN. This webinar is scheduled for March 2017, and we'd like to thank all of you, whether you're participating in the live event or whether you're listening to the archived recording. We'd like to thank you for your time. We are all in this together trying to really improve the cardiovascular care of our patient population. So thanks for joining us. We'd like to remind everyone, just a little bit of housekeeping, that all the lines are currently muted. When you want to have a question or a chat, we'd like to encourage you to use the chat feature and the Q&A feature on the right-hand side of your screen. If you're currently not seeing either of those features, you can use the icons in the upper right-hand corner of your screen to bring both of them down. We'd like to encourage you to use this because of the volume of callers and the volume of participants today. We will continue to keep the lines muted. So we'll get to as many questions and comments as we can. We do want this to be as much of an informal, interactive group, but we've been waiting a long time to present this information, and we're very excited to do that. So with us today, we have Misty Kevich, and for those of you I haven't met, my name is Cindy Sun. And as I said, we've been holding on this topic, waiting for the conditions of participation, or the COPs, to drop. For those of you that have been with us since 2014, we created, I shouldn't say we, Misty created the Quality Improvement QAPI Resources back in 2014 for the proposed COP, and we've been waiting for the final ruling so that she could update those and we can put them out so that you guys will at least be aware of what is available. We know that the COPs are not, the QAPIs are not due for another 9 months, but as you're moving through the year, knowing that you are home healthers and this is an area that you're going to be engaged in, we know that you're going to be progressing through and looking to get these in line if they're not already in place at your agency. So we wanted today to focus on what's available, what is already out there, free, evidence-based. Everything with HHQI is funded by CMS, so it's free to all the participants. And so we wanted you to just kind of touch on what's available and how the cardio work that you're doing now can align for the COPs. Now, we'll just mention to you, for those of you that maybe your objective for today's call is to hear about or confirming any of the rumors of possible delays or changes of the COPs, we have absolutely no information on that. We're participating and we'll find out the same as you will. Probably we'll find out after you do if there are any changes. So we're moving forward with the COPs as they are right now. So we'll go ahead and get started and get a few announcements out of the way. We want to thank you guys for participating. We do have currently at HHQI, since the last time we talked, we have over 17,600 participants, and that's representing almost 5,700 home health agencies. So thank you for that. For those of you who were not able to participate in the National Million Hearts webinar event for February 14th, where Dr. Janet Wright, the Executive Director of Million Hearts, presented Million Hearts 2022, Making More Progress Faster Together. She was able to highlight where home health is fitting and the community providers are fitting into the future of the Million Hearts initiative. That is recorded and on the HHQI website. It's under the tab webinars if you'd like to go and listen to that if you missed it. And also, we're looking to let you know that since we last met, Annals of Internal Medicine published a new article in January focusing on the pharmacological treatment of hypertension in adults aged 60 years or older to higher versus lower blood pressure targets, a clinical practice guideline from the American College of Physicians and the American College of Family Physicians. That's available for free download off of the internet, and I know that some of you are very interested in what is going on in that area, so I wanted to share in case January got a little crazy between the COPs and OASIS C2, so in case you missed that email coming through, I just wanted to let you know about that. Two more announcements. Patient safety. This is an area that everyone is focusing in now. We just wanted to let you know to mark your calendars that on April 20th at 2 o'clock Eastern, the underserved population, that's the UP tab on the HHQI website, will have a webinar presentation titled Patient Safety, All in a Day's Work. And we're doing this so that it will have a guest speaker who will come in and talk about learning how to begin preparing your QAPI plan related to patient safety. So if that's an area that you wish to focus, go ahead and mark your calendar for April 20th at 2 o'clock. And the last announcement is for those of you focusing on the HHCDR. New in 2017 for the Home Health Cardiovascular Data Registry, we know that hundreds of you actually completed the evaluation for 2016, and we appreciate that. Starting next month, as you open the registry, if you have completed 3 months of data and closed out those months, you'll be eligible for a questionnaire that will pop up. If you do not have the time or if you're not in the mood, scroll to the bottom, and there's a skip button, and then you can get right into the registry and continue what you're doing. But we do appreciate all the feedback that we've had from all of you, that it's been so valuable, and we want to continue doing this. So each year, you'll have the same survey that will come up. The difference in this year's survey or questionnaire is just to ask about patient impact. What impact, what stories has your cardiac improvement made? Have you seen it? Specific stories, and I know that you have because many of you have shared them with us. And I'll just mention a couple really quickly to give you an idea of what we're talking about. We had one agency tell us that they had a patient who wasn't taking aspirin, and they should have, they were eligible for it. The agency called the physician and asked about the patient, should the patient be on aspirin, and the physician said, absolutely, I've been on this for so long, I've been trying to get them to take it, and on and on. You know, we've all had the same situation. So the agency goes in, the clinician who is working with the patient, and in one visit, the patient has been taking their aspirin as they should be. And the physician's office had been trying to do this for so long. We know this is the impact that home health clinicians can make. Another one that you guys have shared with us, which was just, I think many will probably relate to this. The clinician is in the home speaking to the patient about smoking and the harmful effects. The patient did not change their behavior, but the family members did. So the fact that the patient continued their tobacco use, that was unfortunate, but this clinician impacted the entire family. So these are the types of stories we'd like to hear, and we know that you're hearing them. And as much as we would like to visit all 13,000 agencies and hear the stories ourselves, we depend on you guys to share with us. So as you come across these stories, if you want to just give us a quick call and let us know, or if you want to shoot it out in an email, any way that we can hear the story, we're happy to do so. So you'll see that question come up on the evaluation, but do not feel obligated. It's just, do you have any impact stories that you'd like to share? So now I'm going to turn it over to Misty Kavich to get us started on our presentation today. Misty?
Thanks so much, Cindy. Welcome, everyone. Today's topic is going to be related to cardiovascular health, but the premise and the information that we're going to share with you today is really applicable to any QAPI performance improvement project you're doing. It's just the content is going to be cardiac focus. You would substitute out. We have lots of resources that we'll share at the end on some slides that you'd be able to find maybe something more specific to another topic. Today there are no free CEs. We often have free nursing CEs, but they are available in HHQI University on this topic, and I'll show you a little bit later today near the end how to go about doing that. So our objectives for today include to align your current cardiovascular QI efforts with the new CoPs and QAPI requirements, to use HHQI Cardiovascular Performance Improvement Project, or what we're going to reference as PIP or PIP tools, to guide through those cardiovascular efforts, to monitor for trends and improvement rates using data from the registry, and for you to find 2 or 3 or more evidence-based tools or resources that could help you improve your cardiovascular health effects. So this slide we use a lot in our presentations because it's a funnel. It talks about what's currently here, what's on the horizon, and we know in home health we even have some new projects or in initiatives that are actually in the funnel. But you can see we've been doing Home Health Star for a while. Value-based purchasing is in 9 states. That is rolled out last year. And the conditions of participation finally did roll out on January the 13th, 2017. So at this point, those are some of the key innovation strategies. We also know there's the Impact Act and some other things that different areas are working on. So what is QAPI, which is quality assurance, using those things where you're really focused on the provider. These are more reactive. These are compliance standards that you've always been doing, but it's merging them in with those performance improvement projects that you have focused on your patients. These are very proactive. So it is combining, really creating a sense of culture for your agency. So who's responsible for QAPI? Well, it starts at the top, and it goes all the way to the bottom. It starts with the governing body, and with whoever, if you have a board of directors or whomever that may be, they're ultimately responsible for your QAPI program. But it does come down to leadership, your clinicians, even your social workers and aides, and your support staff, your office staff, because most of the time they're involved in a lot of daily processes. CMS was very specific in coming out with 5 particular standards, and they really do not stand alone. They run into each other or mesh into each other or support each other. And the first one is executive responsibility. We are not going to go into detail on all of these. We have a QAPI 101 course with material that will really dive a little deeper into that. There is a program scope, program data, program activities, but the area we're going to focus on today is really that performance improvement project. But let's just make sure that we understand what the PIPs are from using this COP language. CMS does not require, and I've underlined that, any specific format or template for your performance improvement project. It can be any way you want. We have provided on the website some samples just to help people get started. You do not need to use that format. Just many of us like to see a sample and gives us some ideas. You are to conduct your PIPs at least annually. And I really think you're going to find that you have to do reiterations of those PIPs frequently throughout the year, but you have to at least annually look at those. And they need to reflect the scope, complexity, and past performance of your agency. And you're to utilize data. It is a data-driven process. And it's to focus on problematic areas that you may have, clear evidence of poor patient outcomes, high risk and high volume. And I'm going to talk about a little bit and give you some examples of those and just a little bit related to cardiovascular. We do have the Home Health QAPI fact sheet that goes along with our QAPI 101 course. This is a tool that kind of breaks the COP down in more manageable language. It looks at interventions and strategies for each of those standards, those 5 standards, and ideas to help you get brainstorm as to how you could implement that at your organization, no matter your size, if you're large or if you're small. We have recently updated all of our QAPI materials and including our course. We thought the language in the draft COP would be pretty consistent with the final version, and it was. Really, the document we did the most revision is in this QAPI fact sheet. So if you already have it, you may want to go out and get the most recent copy. We've added a little piece on infection control because that's an important component, and perhaps have highlighted a few things here or there, but primarily all of the changes came down to removing the word proposed and draft. So really what was in the old is really not outdated. We've just updated it with the new pieces. So for performance improvement, this is the meat of where you're going to get together and you're going to get started to do the work. You're going to be doing PDSA, plan, do, study, act. You're going to test things in during this PIP team. But you have to start by putting together your team. So whatever the specific project you're going to work on, you develop a PIP team. Your members will be different for each PIP that you work on. Some people will overlap, but you have to really look for your specialist at your organization. So you need to have a leader. and somebody that can make decisions, especially when you're talking about processes. You need to have clinical champions, at least one, that could give really good insight, that's not going to be afraid to speak their mind, but it's also going to be that champion when you roll it out. There'll be a tester, they'll test it, and they really will support it when rolling out with the clinicians. Sometimes you'll need technical experts. You may have somebody on the topic that's very specific, or perhaps it's somebody that is very knowledgeable of your EMR or of your processes internally. You may want to have sit in on some of the meetings. Discipline representation. When we're working on cardiovascular, we do want to utilize our physical therapists, our occupational therapists, and other disciplines in our aides, but you may not need to have someone at all of the meetings, but where it's appropriate, and bring them on. And then office support, as I mentioned earlier, they're really that support for us for processes, materials, et cetera. They can provide a lot of insight to your team. So with that, we're going to take a look at topic-specific PIP tools that we have. We have a hospitalization PIP tool, a medication management one, and a cardiovascular health. Now, today we're going to focus on the cardiovascular health, but those others are available, and there are courses to go along with that. So why are cardiovascular health for a performance improvement project? Well, MIs and CVAs are first and fourth leading cause of death in the United States. So that is high risk. Remember earlier on the slides, I said high risk was one of those factors that CMS said you were to develop your PIPs around. Hypertension diagnosis is usually most agencies' one of the top diagnoses, and that could be a high volume. You may have a lot of patients with hypertension, and so working on a PIP to control hypertension would be very valuable because it's high volume. Then also, our HHCDR, or the cardiac registry, indicates that, perhaps a high percentage of your patients are being discharged with elevated blood pressures. So that's showing a past performance problem. So that's how you can utilize the cardiovascular work that you're doing, or if you've not started working on cardiovascular, there's lots of information that will be provided at the end of finding out information about more on the cardiovascular registry. Okay. Next, we're going to turn the presentation over to Cindy to continue here.
Thanks, Misty, and hello, everybody, again. So let's get started with step one when you're doing your QAPIs. And I think that some of this will be a repeat for some of you, but others may be hearing it for the first time. So let's go ahead and start with step one, which is data collection. Assess the data. Now, there are many different data sources. Whether your data sources are, as every CMS reporting home health agency has access to, you have access to your KEYS data, which is CASPR, your OBQI, your OBQM. And remember, CASPR is very, very broad. It covers every single OBQI, OBQM measure that you could be thinking about coming from the OASIS with a little bit of claims data sprinkled in there. You have access to Home Health Compare. Home Health Compare, as you know, is the publicly reported risk-adjusted data, and that is coming also from the OASIS as well as a little bit of claims data. You also have HHCAPs, which are located on Home Health Compare, and then you have the HHQI Data Access System. With HHQI, you have access to its OASIS base. There is no claims data. It is all your raw data, and it's very deep on a very narrow focus of outcomes. We're looking at ACH, oral med, flu and pneumonia, immunization rates. That's it, but it's extremely deep. So if those are the topic areas that you're wishing to focus, those are the areas to pull these reports, and hopefully it will help you drill down. I've said this many times, I'm sure that it's still true. There is too much information out there, and there's still 24 hours in the day. We don't have time to address everything. And by saying that you want to reduce hospitalizations, that's wonderful. But how exactly are you going to do it? And the HHQI reports will help you drill down. What we're here to talk about on this call today is the Home Health Cardiovascular Data Registry. If you have done your assessment in your agency and you have found that cardiovascular patients are hitting the emergency room and being hospitalized more frequently of your patient populations when you're looking at disease management, then this registry will help you drill down. Instead of saying, I'm going to focus on, well, our agency is going to focus on improving cardiovascular health. That's great. But what part of cardiovascular health specifically are you going to address? And that's where the registry comes in. So collecting your data, doing a data assessment for your agency, allowing that data to be suggestive of where you focus your agency's intentions, where you focus your resources. It's in a perfect world, we would have 40 hours in a day, and we would have billions of dollars to spend. And we'd have 13,000 people in our agency just working on improvements, but it's not realistic. So allow the data to drive you. So with the registry, as many of you know, this focuses on aspirin is appropriate, blood pressure control for your patients that have a diagnosis of hypertension, for your patients with a diagnosis of diabetes or a cardiovascular disorder, what is the cholesterol? And smoking. Was your patient assessed for tobacco use? And if they were found to be a tobacco user, did your staff or did you perform 3 minutes of counseling? That's pharmacotherapy or any type of counseling. 3 minutes, that's it, during the entire episode. Now with this in mind, let's say you've done your entire assessment of your agency. Your agency is doing great. You have decided that you don't have a high cardiovascular population, and that's not where you're going to focus your energy right now. You at the agency will know what is best for your agency, but the data needs to drive you to that point. Well, if you found that, let's think outside of the box. If you are focusing on, you have found that your patient's wounds are just not healing as quickly as you wanted them to, or maybe you're finding that you have other disease processes that are causing your increased hospitalization and emergency risk. Let's say that your respiratory patients are hitting the emergency room a little too frequently and they're more frequently than the rest of your patients. Think outside of the box of how to use this registry as a tool. If you're focusing on wounds, your wound beds are not healing as quickly as you want them to. Well, if you're doing wound management, more than likely you've got a tobacco program in place. If so, you can use this registry to collect your data. You don't have to recreate it because it's here. Let's say you're focusing on diabetes. You have a very high diabetic population and they're just going to the emergency room too quickly or too frequently. Remember, the patients with diabetes, cholesterol is going to be in your disease management program. You can use this registry, even if you're not focusing on cardiovascular, it will pull 50% of the patients when you pull cholesterol will be diabetic. So think outside of the box. You know, you're not in home health by accident. The fact that you're in home health indicates that you practice within your boundaries, that you think outside of the box. There's so many of us that are from the very old days where we would take the picture off the wall and hang the IV bag on the nail that's sticking out of the wall, or you put it on a coat hanger and stick it over the curtain rod. Whatever you need to do, you get it done. So keep in mind, this is available. And like I said earlier, this is one of our main goals today, is to share with you what is available. So as you are moving forward in your cardiovascular or even in your QAPI development, you'll realize these tools are available and they may help you. The last thing I'll mention about thinking outside of the box is think about those, if one of your objectives for your agency is to align with community resources, other community providers, or maybe you're wanting to increase marketing, think of how all this will help with that as well. We're happy to help you with any of this, but it comes right down to using the registry if it will help you drive your quality improvement. So a few details about the registry. For those of you that are not using it, you access it through the data access portal. Every month, you as the agency, you get to select, well, I shouldn't say get to, but you're the ones that select which of the ABCS topic areas you wish to focus. Mix and match, switch and change, however you want to do it. You hold all the control here. Whatever focus you choose, it's pre-populated with episodes with the demographic information coming off of your OASIS. So all you need to do is answer the simplistic questions such as, is it aspirin? Was the patient taking an aspirin or another antithrombotic, yes or no? If it's blood pressure, what was the last blood pressure? You'll have 12 or fewer episodes per topic area that will be in the registry itself. The qualifications are listed here. I think most of you know those, but in case you don't, if the patient has been cared for by your agency for 2 weeks or longer, they'll be eligible for the registry. So the patients that you've seen for a week, they're not going to be in the registry. That was intentional. Your patients are not coming to you because of aspirin therapy or because of smoking in most cases. They're coming to you for other big issues. So these issues, the ABCS may not come up in the first 2 weeks, so we remove those patients from the eligibility because you've got other things to deal with if you're only going to care for that patient for 1 week. There are individual age requirements that impact whether the patient qualifies for which one of these ABCS categories. And I put these on here in case you were trying to figure out where to focus. So if you have your patients that are going to the emergency room with unstable angina, or sometimes even admitted for unstable angina, look at their blood pressure. Did this patient have hypertension before? And if they did, was their blood pressure controlled at 140/90 or lower? Or were they in the 180s and 190s for the past 2 weeks? Could that emergency department visit have been prevented? Those are the questions you'll want to ask to decide if that's an area you wish to focus. So to access this, you would go to the HHQI website, click on data, and it takes you into the data portal where you'll click register if you have not already created an account. If you have access to the HHQI data reports, the ACH, oral med, or immunization, it's the same login. So don't worry about it. If you already have that, you're good to go. You'll find all the additional resources to help interpret your reports. You'll get these reports on a monthly basis, and they'll come through right here. Now, just as an example of what reports are available to you, we just pulled out the smoking cessation just because we needed something to highlight today. I'm not going to take you through all of the ABCSs that are available, but if you choose the smoking cessation is an area you wish to focus, and that's where actually most of you are focusing, so I wanted to bring that forward. You'll see at the top of your report in the blue box the actual criteria, and then this is your report that you get every month. So you'll notice it's a 12-month rolling report, and then you'll have your totals on the right-hand side in the yellow column. And this is actually, it's not highlighted for the purpose of this webinar. This is actually coming off of a report. It's our fictitious report. And you'll see in the top number of episodes that were screened and received cessation interventions. That is actually meeting the measure. But we also wanted to include the total eligible episodes that were available for the agency to abstract. So if we look at April, the column on the right next to the yellow, we can see this agency had 36 eligible episodes, and of those, 31 did receive cessation counseling. That gives this agency, they've met this measure with an 86.11 compliance rate. Now, compared to the rest of the country, you can see the bottom row. The rest of the country, and we call that total data registry measure compliance because of the fact that this is not a mandatory registry. We can't call that national, so we're calling it total data registry. So of all the agencies that entered data, they were hitting about an 88% compliance. That lets you know you're a little bit low at your agency, but it gives you something to compare. Step 2, you've assessed your data. You've decided where it is you wish to focus. Let's say you've chosen smoking. The next step is to develop the goal. How are you going to know when you get there if you don't have the goal? So in this PIP tool that has been created, you will notice this is a page from it. And don't worry, you're not expected to read it, but I just have the blue arrow there pointing out. This gives you an example of an expected outcome, but be understanding that in no way, shape, or form is this a template. CMS was very clear that they want every one of you in an agency to have the autonomy to create your own way of doing this. But we just put this together to kind of give guidelines of what's expected. So you need to have some sort of a goal, and it needs to be measurable by all means. You need to have it as, where's your data source coming from? How is it going to be measured? And in what area, what data source are you getting it from? So as an example, you may want to say that your goal is to have an increased compliance of tobacco-using patients receiving pharmacotherapy and or at least 3 minutes of cessation behavioral counseling. 2A, what % do you anticipate as a goal, and what is your date? Keep it realistic, keep it measurable, and then put whatever your data source is that you plan to use. Another tool that has been developed, and again, it's not meant to be a template, it's just to give a guide. We had so much feedback from agencies just saying, give us something, we need something. So we created this QAPI Canvas. And it will, and again, I'm not expecting you to read it, but I wanted to let you know that it's available. And it helps guide you through the steps of what you need to do to create a QAPI, whether it's for cardiovascular or any of your other topics. Fill it out and move on down through it. It will give you a guide of where you are, where you need to go, what steps are you missing, and as Misty mentioned, any of the steps that you have questions about, you can revert back to the tools on the HHQI site. It's like, okay, wait, I forgot all about, what is this I was supposed to be doing? And review it. Get the information, get your feet under you, and then you can move forward with it. The final thing I wanted to just mention is that for those who are not familiar with rapid cycle improvement, and that means that you are looking to make an improvement not for 2 years down the line, but you're looking to make improvements immediately, say in the next week, and how to start small and spread. The IHI, we were just so fortunate. IHI offered to do this series for us, and it's now about 2 years old. But the thing is, it is still current. So if you are not familiar with rapid cycle improvement, please take a few hours, and I know a few hours, we're talking, that's a few minutes is tough to come by. But before you put all of your effort into quality improvement, especially developing your QAPIs, if you are not familiar with rapid cycle improvement and how to initiate the spread, IHI did a phenomenal job of creating this 4-part series and helping to develop and how to move into it. This will save you a lot of time in the long run. So this is a 4-part series. It's been turned into a university course where nursing CEs are available, and it's out there on the website. You can take it. It's asynchronous. You can do it in your own time, in your own freedom. And maybe this is not something for you. Maybe it's something you want someone else in your agency to watch so that they can learn and share the information. This is what's available, and hopefully you'll find it useful. So moving on to next is step 3, and I'm going to turn this back over to Misty Cavich. Misty?
Thanks so much, Cindy. Okay, so as we continue down our steps, we want to take a look at drilling down the interventions, because there's a lot of different interventions and strategies, and you have to figure out what's going to work for our organization, what's going to give us the biggest bang for our buck, what can we integrate into our current processes, and start there. And you never want to start with more than 1 or 2 interventions. You want to test them to see if it's going to be effective. You can always build upon that. And that's the language that came with the COPs, is that they're going to be looking for you to make improvement and to sustain that improvement. So it's not just getting the, your rates improved, but then you have to sustain it. So start with 1 or 2, test it, then continue on. So where do you start? Well, we have in the PIP, the cardiovascular PIP, we have sections within that toolkit that you'll get. And there's an aspirin as appropriate, a blood pressure control, cholesterol management, and smoking cessation. And you're just seeing 1 page of the smoking cessation, and it's just to give you an idea of how to leverage and utilize it. It is a document that's kind of nice to have printed if you're going to be at a work group, but it is ideal to be electronic because there are tons of hyperlinks that are going to get you to the tools and resources. So as we start through this tool, we will see that sorry, I'll just get my mouse moving here. On the left side is actions or interventions. And this is 2 pages, I believe, for the smoking cessation. But it's common problems that you may have at your organization. So you go down, try to see what might be the area. There's some ideas and intervention strategies related to that problem area. And then on the opposite side, there are related resources. So this will give you links that you can go out and take a look at, learn from, bring back to your PIP team to maybe consider. So that's what's in this package. So then we'll move into step 4 because there's lots of resources out there. But what we'll need to do is now you need to select those tools and resources. You might have looked at those, and how do you start picking what works for you and where do we go? Well, what we do for evidence-based practices for HHQI is we create what we call as best practice intervention packages, or BPIPs. There are 4 that relate to cardiovascular health. There is cardiovascular health part 1. This includes aspirin as appropriate and blood pressure control. So if either of those 2 areas, this is kind of the big daddy. These are big packages with lots of tools, resources, lots of the evidence base that has the current guidelines included. So that's where you would go. In this Part 2 is the cholesterol management and smoking cessation. Those would be the areas, obviously, for those 2 areas. Now, we also have what we call a fundamental focus, blood pressure control and smoking cessation, because those are the 2 primary of the 4 that agencies are working on and really are very applicable for home health. So we did a smaller package. This is down and dirty. These are key resources that you should consider. It's just full of great resources and ideas of how to integrate it with your therapist, social workers, and aides. So this could be a package you might want to start with instead of the Big Daddy. And then you can always use that Big Daddy as a resource. One of the other focus BPIPs we have is the cardiovascular health for at-risk populations. If you deal with a very diverse population, we know that blood pressure control is much more difficult for African Americans and some Hispanic populations. And so you can learn more about populations, some tools and resources related to that, those audiences. We have a variety of clinician tools, and we're just capturing just a couple tools for you to highlight. And if you've been on similar CardioLAN calls where we've highlighted some resources, some will be repeats, but we are trying to show you some new and different resources that we do have available for you. Everything is free that you can utilize. We have 2 great clinician videos. We have smoking cessation with your patients, and populations for at-risk for heart attack. These are great. They're about 10 minutes apiece. You could use it during a team meeting to open dialogue or to jumpstart your work that you're going to do. So those are great videos. We also have a course in our university, HHQI University, and this is the Tobacco Effects and Cessation Medications. This takes an in-depth look. It's about an hour long, and it talks about the effects of cardiovascular system related to tobacco smoke. And it goes even into blood pressure, which components of the tobacco causes the blood pressure to rise, and the neurotransmitters, et cetera. So it's really very good. It also goes over a variety of cessation medication classifications and including their actions. There is free nursing CEs, 1.0 hours for that course. Now here's a couple tools I'm going to show you. This first tool is the various drug it talks about various drug classifications and the mechanisms of interactions and effects with tobacco smoke. Because if a smoker is taking any type or a lot of different medications, it will impact those other medications. So for example, this one-page sheet is going to give you some examples of which drugs are going, which interactions are going to occur from the tobacco that may increase or decrease the drug's clearance, the plasma concentrations, and the effectiveness of that medication. And there are many drugs in this on this tool that will say patient may need to have a higher dose of their regular medication because it's going to be diminished because of the smoking. So this is a really good tool that could be a good clinician tool. The other, which is one of our most popular clinician tools related to smoking cessation, is the FDA-approved meds for smoking. So it gives the classification of the meds, how it works, how each of the components are available, and it's a really good guide for clinicians, especially if you are very unfamiliar with the medications that are been approved. The next tool is the coping with quitting, and it talks about the cognitive and behavioral strategies. So this is a good tool because it provides some examples of what a clinician can do or how to get patients to get motivated cognitively. So things such as like, you know, some positive talk, you know, like each morning you need to say, I'm very proud I made it through another day without tobacco. And it talks about some behavioral strategies such as stress reduction, alcohol usage, and it goes on. So it's a really good tool for clinicians to learn from just by reading. It's very simple. The next tool is a two-page tool, and it's relapsed smokers who are ready to try again what to do. And it is based upon the three-step protocol for clinicians that is featured within our BPIPs and other tools and resources. It's that ask, advise, and refer. So there are questions, and they will help clinicians to initiate the conversation. Like, tell me about the last time that you attempted to quit, or did you use a smoking cessation medication, and how did that work, and how did that feel? And then it goes into advising. Well, like according to the most current research, the best way to quit is using a combination of smoking cessation medications and a behavioral modification or a program or counseling. You know, which of these do you think would work best for you? So they give really good suggestions and ideas for you to integrate. And then there's the refer. Here's some suggestions. You know, what do you think might work best for you? The 800 quit hotline, some support groups, and then it gives you some other ideas. But again, it's to help work. Many patients cannot quit the first time, so that's unexpected, and we want to show them that it is more effective to be able to use the meds with the counseling or the other supportive services. And the withdrawal symptoms sheet is one I really love because if a patient knows how long they need to hang in there, you know, as they struggle hour by hour, minute by minute, I think that is very beneficial. I know recently I used this sheet with one of my father's friends who quit smoking, and she's like, I don't think I can do this. I'm a week in and I just don't think. Well, actually, most symptoms occur within that first 1 to 2 days. They peak after that first week, and then they start to subside in 2 to 4 weeks. Well, knowing that, you know, brought much relief to her. She was halfway through the worst of it, you know, and starting to make some progress. And there, not only does it provide the simple symptom, it gives the cause, how long it's going to last, and some ideas for relief. So this is a good clinician tool to help us educate, but it is also a good patient tool. Now we have a couple more videos. We have the Smoking in Your Heart, and we have How to Quit Smoking. These are simple videos that can be used. They're about 7 to 10 minutes each. It can initiate for clinicians to talk about smoking cessation, or it can be an adjunct or reinforcement. So if you're seeing patients, you know, with cardiac, high blood pressure, any cardiovascular disease, do they really know? And there's pictures and graphics, seeing that heart pumping and what the tobacco, you know, picture is, you know, worth 1,000,000 words truly, or 1,000 words. So these are really great videos of interactions with a clinician and patient so that they could see a relevance to themselves. One of the things that patients often do is they believe myths, things that they have heard. And this is a CDC pamphlet that you can utilize. We do have that available in Spanish as well. It's 2 pages that talks about common myths, and then it debunks those myths. We have another patient tool within one of the best practice packages, but it can be standalone. And it talks about interventions as the 4 Ds. You need to distract yourself, do some deep breathing, drink water, do something else. If you can do those things when you're really struggling in the moment. So this could be a great patient handout that you provide them to give them ideas of what to do. Sometimes they're just so overwhelmed with their anxiety that they can't think. But if they have a handout and we reinforce, think 4 Ds, 4 Ds, let's get your sheet out, that they'll do that when they're in that moment. This next is dispelling myths about nicotine replacement therapy, which is one of the most common cessation medications that are used. So it is a patient tool that can be given to them, or it's something that you can use as a clinician in talking about this with your patients and dispelling some of the myths. We have a My Healthy Heart workbook that talks about the ABCSs, and it has sections for the patient to complete or to think about. Ideally, you ask them what section they want to work on, and they are available in all of those languages. And now we'll move into step 5, which is to evaluate. So we're going to take a look at what are your next steps. So I think from some of the text messages and the Q&As that have been coming in, I think, have you begun submitting data into your HHCDR already? Some of you are. But some of you, this is new, so that's great. That can be your first step, is read more about the cardiovascular FAQs. We have, those will be on a slide that Cindy's going to show you. That'll give you more information. Get on the website, learn a little bit more. But if you've already begun to submit data, and you have selected, one of the ABCS measures, then you may be ready to move on to the next box, the already abstracting, and you want to evaluate your current data. So, are you looking at your reports on a regular basis? How are you doing? Have you looked at your trending? And that'll be part of the next step as well, that maybe you're ready to even add a new ABCS measure. Maybe you're doing smoking cessation, and you are doing fairly well, and you're ready to take a look at maybe the blood pressure measure or, or the reverse to that. So if you have decided on that area for your PIP, your Performance Improvement Project, you really now need to critically look at your data. What does it say? What are your areas that are high risk, high volume, or will impact your populations? And what key tools and resources from that PIP tool could you use or contemplate using at your agency? Cindy showed you that QAPI Canvas tool with the paint colors and all. That's just to help you get started with designing it, but that's a great way to easily get started with your performance improvement team in jump-starting what you're doing. And then these are some QAPI resources. I mentioned earlier that we have a variety of tools, including this cardiovascular health PIP tool. So we have on this slide, and they're all hyperlinked for you to get to the tools, and an example for each cardiovascular health, hospitalizations, med management, that Canvas tool. The university has specific courses that you can go in and get CEs and go through each of those in more detail. And then I also have included here the final rule for the COPs. And Cindy, I'm going to go ahead and turn it back over to you.
Well, thank you, Misty. And everybody, as you are starting to formulate questions, go ahead and send them in through the Q&A box, if you will. That way we can answer as many as we can while we're on today. And if we're unable to answer all of the questions, we will go ahead and figure out a way to get you the information afterwards. And for those of you that are having specific login issues or things of any specific questions about your data that you would like to discuss, I appreciate the fact you're not discussing it on here, and we definitely want to keep the data private. We treat the data, not only the HHCDR, but all of the HHQI reports, we treat that at the same level that you treat your PHI. So we want to have those conversations one-on-one. So thanks for doing that. And we'll go ahead and move on into this. So we're talking about the resources. As Misty has mentioned, there are many different resources available through HHQI. And again, our goal today is primarily to help you become aware of what is available before you enter into this. So the links are on here that Misty has mentioned that you can access all of this information. And we'll go ahead and just stop for a few questions. And I see the first one coming in as, are the HHA PIPs published in public? Absolutely, they are. If you're asking about the tools and resources for the cardiovascular, medication, and ACE in hospitalization, those are found on the HHQI website under the Education tab. Once you hover over the Education tab, you'll see a drop-down box which includes the word quality. I'm getting there now so I can give you the exact wording. But if you're looking for the courses, you'll go under Education and look for Resources under the university. And the wording that you'll find on the drop-down under Education is QAPI Resources, and that's where you can find all of these to help guide you through your process. And then the next question I see is, often there are notes that the patient had cholesterol checked, but the raw data is not present, so we are marking no under the screening. Is this correct? To answer that question, it would have to do a little bit more detail, but more than likely you're answering it incorrectly. Give yourselves credit for the fact that it was checked, but you need to know if it was checked within the last year. The question is, the drop-down options include under cholesterol, what this person's referring to is in the registry. Sorry, Jenny. I'm sorry, Jenny, I didn't use your name there, but what Jenny's referring to is if you select cholesterol, you're asked, was the patient screened for cholesterol in the past year, yes or no? And in this case, you would say yes, because the fact is the patient was screened. And your next question is, how were they screened? And one of your options is that's LDL, HDL, but then also there is an other where you can write in physician notes or H&P. That's fine. So that lets you know that they were screened, you just didn't have the LDL. Now, while we're on the topic, I will just share with all of you that are on the phone that if cholesterol is an area you're wishing to focus in on, that's especially for those, not just for cardiovascular, but for patients that are diabetic. What we've heard are two schools of thought. Even if you are a hospital-based home health agency, the two successes that we have heard is either they have put this responsibility on the intake coordinator. So the intake coordinator is asking for the referral for, they want the order for home health, they want the H&P, the med list, the immunizations, and also the LDL panel, or the HDL, or the cholesterol panel. Putting it as part of the intake information that is obtained from the upstream referral, whether it's a physician's office or a hospital. The second school of thought that we have heard that has been successful is making it the responsibility of the start of care clinician. So whenever the start of care clinician is completing all of their information, if that LDL or cholesterol panel is not there, they're putting it as part of their repertoire of talking to the physician or the physician's office upon the start of care and getting the orders. Whatever works for your agency, by all means do it, but I just wanted to share what agencies have shared with us, which some of you have shared with us in the past that has worked. Cholesterol is one of the toughest ones. I think the most common thing I hear from agencies are those that are hospital-based who were under the impression that it would be a simple lab result to get, since they usually share lab results with the hospital, and it's not as easy as it seems. So we do know that that is probably the most, without a doubt, challenging focus, but successes have occurred, and we're very happy to see those. So thanks for those of you that are participating in it and those of you that are looking at going into cholesterol as one of your focus areas. Maybe those tips will help. So at this time, we're not seeing any other questions. We'll check the chat.
Cindy, we do have a question from Jenny.
I'm sorry, what's Jenny's question?
Jenny wants to know if there are notes, let me read this again. Often there are notes.
I answered that one.
Oh, I'm sorry. I thought you hadn't. Okay, thank you.
No, I'm sorry.
I just want to make sure we covered it.
And Misty, I do the same thing. While you were talking, I was tuning you out, and I was thinking, oh, my goodness, I'm not listening to Misty as I was answering questions, so I'm glad that you caught that. Okay, and there was a clarification. If I answer the questions incorrectly, if I'm not answering what you're asking, please let us know, because we definitely want to get your questions answered. And it looks like, Rebecca, okay, Rebecca, it looks like I did answer your question. Great, because we do want, you know, it's tough whenever you're reading text questions, but with the volume of callers today, we didn't want to open the phone lines and inadvertently somebody would have us on hold, and and some of the hold music is actually quite entertaining, but that's not what we want on today's call. So Misty, since we have no other questions right now, I'll turn it over to you if you have any final thoughts before we close out the call today.
My biggest piece of advice to you is to get started. You do know that the performance improvement projects, so I guess we didn't say that today. So it is written into the current final version of the COPs. Your PIPs, your performance improvement projects, let me make sure I get that out correctly, will not go into effect until January of 2018. What they have done is given you a year from the date of the release to begin to start to look at your data and then start writing your PIP plan. But if you're already doing this work in the cardiovascular data registry, and you're already starting to do interventions, and even if it's one intervention at a time, you might as well get it down in writing as a formal PIP. That's one piece that you're going to not have to have on your plate forward. Plus, it's a quality improvement plan. It's good evidence-based strategies and practices anyway. If you're an agency that's certified through one of the certifying organizations, you're already doing something like that. So go ahead and make sure you get your plan written, you're keeping track of it. Don't add more than 1 or 2 intervention strategies at a time. Plan for reinforcement and sustainment. Those are critical.
Well, thanks, Misty. One final question, and then we'll close, is how to register for the HHQI University courses. When you're on the HHQI website, if you hover over the Education tab, you'll see HHQI University, and you can click on that. Do remember, this will be an independent registration. We understand that that is a pain, but we need to do it that way because this is tied to your CEs. But do remember, even though nursing CEs as well as therapy and social worker CEs are available through the HHQI University courses, every person can take these courses and receive the certificate of attendance. So if you are looking to embed some of these courses into your quality improvement plans, that's fine to do. Your clinicians, as well as your home health aides, your social workers, everyone can take the course, even if CEs are not offered, and they will receive a certificate of attendance. We've heard some great success stories on that, so we want to thank you for that. So in closing, I will just mention a couple things. One, I want to remind you about setting your calendar for the patient safety webinar, which is 2 p.m. Eastern on April 20th. I want to mention that our next meeting together, the June CardioLAN, will be on June 15th. And we are so lucky. I just can't get over how lucky we are. But June 15th, we have speaker Melinda Huffman will be focusing on ways to increase patient engagement and patient self-management, which is critical with the cardiovascular patient population. And we've applied for both nursing and social worker CEs for that session. So you can set your calendars now for June 15th. Now, upon closing today, you're going to be redirected to the CardioLAN page. If you are not already a member of this group, we encourage you to join. You'll be one of the first to be notified of upcoming cardiovascular learning action events, such as this one. As with all HHQI communications, we're very respectful of your email address, and we consciously limit the volume of email messages that we send. As a CardioLAN member, you will receive 1 email a month pertaining to improvements of cardiovascular care, and that's it. And by participating in this group, you will have reached milestone 1, which is your first step in the milestone path. So you'll be redirected there. We encourage you to join so that you can learn about these things that are coming up and then decide if it's something that you are wanting to focus on or not. So with that, we will say thank you very much to everyone, whether you're listening to the recording or you've joined us live today. We hope that this information will be helpful. And by all means, contact us with any questions that you have, because we're very happy to work with you individually on your reports, on your quality improvement, anything that we can do to help you help your patients improve their cardiovascular care. We'll say thank you, and everybody have a wonderful spring. We will see you in June. Bye-bye.